Hello, everybody. Welcome to the Independent Sage. This is a committee of leading scientists set up by Sir David King, the former Chief Scientific Advisor, to offer scientific advice and recommendations on the COVID-19 crisis. First and most importantly, thank you so much for joining us today. Today is an important day and it sees the publication of Independent Sage's interim report on test, track and trace, or find, test, trace, isolate and support, as we're about to hear. But today's event is more importantly an opportunity for the group to hear from you, the public, to ensure that the report is answering the questions that you're asking. I'm also joined today by Kitty Teague. She'll be feeding in questions from the public and members of the committee. First, let me throw over to Sir David, who is going to introduce the report. Sir David?
Thank you very much, Zach. Let me just first of all say our nation is facing the worst economic crisis since the 1940s. And in order to restore the economy and jobs, we must get COVID-19 pandemic out of the way. And in order to achieve that quickly, we went into lockdown, and the lockdown in one sense has been successful. The number of new cases has been falling since the 8th of April. But of course now, as we begin to see some elements of the lockdown being removed, we know that every new case must be found promptly, tested, contacts traced, and the new case and their contacts isolated to prevent further spread. And those people given the support they need to continue with their lives in the lockdown, in the isolation. Now, in this process, we have looked as a group of experts from the medical and healthcare sector in particular, but the behavioral science sector as well, at how we can produce a workable system. And basically, the reason I use that word workable is because we're really questioning whether the current system is capable of operating to the level that I've just stated. And this system is, first of all, changing from simply describing it as test and trace. We're saying this is a find, test, trace, isolate, and support process. Find, we know that about 2 in 5 people infected with COVID-19 never get symptoms. That means it's critically important to pick up all of the people who are showing symptoms. So find is a critical part of this process, and it needs a strong public information campaign to inform people of what the symptoms are, the need to get tested, and how to get tested. Critically, how to get tested. The second is the test must be easy to people to get a test, including those who are frail or lack mobility, non-English speakers, those without internet. People tend not to ask for a test until day 2, at least, of the symptoms, and therefore test results need to be available within 24 hours. I take on the trace. 80% of contacts need to be traced, and very quickly. People won't provide contacts unless they trust that the system and understand the needs. Contact tracing works best if delivered by trained personnel within local communities, and that's a key to our recommendations here. Isolate. The main way that this process operates and suppresses COVID-19 is through isolating the contacts of the infected people. We must never underestimate the importance of this step, and it must be referred to always when we talk about testing, tracing, and isolation. Contact tracing, there needs to be strong public information about the need for isolation of contacts. We need a campaign of giving information about this importance. And then finally, support for isolation needs to be provided where there's financial support needed to compensate lost income, where there's accommodation for those who cannot isolate in their current residence needed, And finally, we need to follow up to check symptoms and well-being. Now, all of this is contained in our report, and I'm now handing back to Zach.
Thank you for that introduction, Sir David. We've got quite a few questions from the public to get to. What I just asked for those within the Zoom, if you could turn your camera on and unmute yourself when you ask your question, and then turn it off and mute yourself when you're not on. So the first person we're going to go to is Kavita Baldwin from Nottingham. Kavita, can you introduce yourself and perhaps tell us what your question for the panel is?
Yeah, sure. So my name's Kavita Baldwin. I was lucky enough to participate in your previous event, so thank you for including me again. I'm from Nottingham, as you mentioned, and the reason for getting in touch is that, as articulated by Sir David, I feel that we've reached the point in the pandemic where we're absolutely desperate for TTI to work. I think if we're going to have any hope of containing the virus, it's essential that it works effectively. And I suppose I've got several questions, but I'm going to restrict it to one. I'm a bit concerned about the direction of resources with the pandemic. So just to give you an example, there seems to be a lot of money being thrown at vaccines. Now, clearly they're important, but they're not going to be the short-term solution to this problem. They may never be the answer. And what I'm wondering is, are there economic models that demonstrate the value of resource being directed at TTI versus things like vaccinations? And to what extent can those sorts of models be used to shift the way things are progressing at the moment?
So David, would you like to take that first?
Yeah, let me just say, I don't think we should at all be making a choice between these two things.
Sure.
In other words, we need vaccines to be developed. That is a clear way out of the pandemic, but we cannot rely on the development of vaccines. So actually, we need investment in both the TTI, or as we're calling it, the FTTIS. We need both, and we need them properly invested in so that our economy can recover quickly. I don't know, I've got Gabriel
Professor Gabriel Scally, do you want to come in?
Yes, it's a great question, and I agree with Sir David, it's not an either or, but there is an economic question about the whole find, test, trace, isolate, and support process. And not investing in it, I would argue, probably will have very significant financial consequences. Because if you look at countries where the virus has been eliminated using that mechanism, they are able to resume economic activity, remove their lockdown restrictions and get on with their lives much earlier. I think one of my personal worries is that unless that system is efficient and effective, we will bump along with a continuing infection with hotspots, with flare-ups, maybe even a second wave. And that, I think, will create much, much more damage than investing in the system, a proper system, an effective system. And one of the things that we could use, which would make great economic sense, would be to use lots of the staff who already are well trained, our public health nurses, health visitors, school nurses, the environmental health officers who do testing and tracing, contact tracing and finding cases all the time in foodborne disease. And we're not making use of those resources. And this report suggests that we should be basing it on local, and we should be intensifying what we do.
Thanks. I think Professor Anthony Costello wanted to come in, and then we'll go back to you, Sir David.
Sorry, Kavita, I do know of one study that is just being submitted to a journal. It hasn't been published yet, which is exactly what you asked for, is an economic assessment of find, test, trace, isolate. And it shows huge potential benefits in terms of economics, because if you don't get it, the damage to the economy is absolutely huge. The only second point, I'll endorse what Gabriel said, which is that if you make use of your local systems that are already in place, the NHS, then and tweak it a little bit, that you're going to actually have a much more cost-effective program than some of the ideas that have been coming up with so far.
Yes, so if I could just come in rather late with this to welcome Steve Reicher. We have a new behavioral subgroup, and Steve Reicher is here. He's Professor of Behavioral Sciences at St Andrews, and I just wanted to welcome you, Steve, to the group. Back to you, Zach.
Thank you. I think we have another question from Ravi Naik. Ravi, if you could tell us where you're calling in from and ask the panel your question.
Hi there, everyone. Yes, my name's Ravi Nayak. I'm a solicitor and the legal director of a new data rights agency called AWO. And our agency works to further the rights of individuals over data and technology and modern technology. And a big part of the work we've been doing since we've launched is to look at the technological responses to COVID-19. We published a detailed legal opinion on the human rights and data protection implications of the technology, as had been proposed earlier in the course of the pandemic. And I'm really glad that you've taken this approach to looking at the test, trace, and isolate system as has been deployed, because we've seen a real evolution in the proposals from the government. I mean, test, trace, and isolate has been throughout one of the key responses to the pandemic. And first we had this bespoke app where the government really went alone, went away from the direction of other states, and even the technology companies that were really putting this in place really departed from the position of Apple and Google on this. And now we see that the app has become secondary. It's the cherry on the cake instead of the cake itself, I think Matt Hancock said. And now we have this test and trace call center. And it seems to us in the course of our work that this system has been put in place without any risk assessments being done, legal obligations to conduct these risk assessments, and secondly, without proper privacy notices as to what's going to happen with the data. And that's given rise to two concerns for me and two questions for you. Firstly, this failure to conduct this risk assessment isn't just a technical failing. It's not just something you do to tick a box and say, I've complied with what the law requires, but it really betrays a rushed out version of this system. The system is meant to be so important to our response to the pandemic. It's been rushed out, and it really betrays the lack of assessment of the risks inherent in this system, and to really understand what it's for and what it's trying to achieve. And as you put in your report, there's actually more that should be done inherent in this. Do you agree with that kind of position, that maybe we've rushed out this system to try to address something at speed rather than to understand what the objective is and put in place a system to address those objectives? And secondly, this system has been put in place at a time where our personal data that goes up to the NHS is becoming increasingly put into the hands of private entities. And we see that with the NHS data store particularly. And it's not entirely clear from the test and trace system as has it been deployed and from the privacy notice, whether that data is going to go from the test and trace system to potentially this NHS data store, and the ingraining of the private sector into the NHS, and particularly our valuable public good that is our personal data in the NHS's hands, is increasingly getting into the hands of private actors. And it'll be really interesting to hear your thoughts on if that's something that we just need to take as part and parcel of the development of this system, or if it's something that really should be a concern. Thank you again so much for having me and for your report. Thanks for your questions, Ravi. Conscious of time, if we can keep the questions and answers a little snappy. Alison Pollock, I don't see your hand up, but I suspect, Professor Alison, that this might be one for you.
And I think we do partly address them in the report. Can you hear me, or is it better with my video off?
We can hear you okay.
Okay. You're absolutely right. I just make 2 points. We didn't rush it. The government has put in a centralised, privatised parallel system for contact tracing that's had no evaluation and no risk assessment, and the data governance has not actually been established. And it's completely bypassed what we already have and know that works, which is a system based on the notification system. It's based on GPs, public health and local authorities cooperating. So as a result of putting in this system, there are so many questions that arise. You've already mentioned them, but I think a key one is what is happening to our data. In the system that is established and the formal system, you're supposed to have data flowing locally, very detailed data on postcode. And that should be on the suspected cases, not the actual cases at this point, but suspected cases. And that should be flowing to the public health departments from the GPs. And what is happening instead is that the data, such as they are, and they're very incomplete and problematic, are flowing centrally up through to NHSX and then into the Biosecurity Centre. And we do not know what the purpose and the function is of this centre yet. It's so serious that the Joint Committee on Human Rights has actually got draft legislation around the whole issue of data protection. It feels there needs to be primary legislation. I won't say any more, but we will thank you very much for your comments, and we will expand on this in our next report.
Thank you, Professor Pollock. Professor Stephen Riker, I wonder if you have any comments on this from a behavioural point of view.
Absolutely. I mean, the first thing is, this might be my only contribution to this group. We're all having problems knowing what to call our system. One acronym that might work is FITTEST, as in survival of the fittest. That covers it all. So that's my contribution to you. On the behavioural science, however, trust is central to this system. It will only work with trust. It is a multi-stage system which leaks at every level. People, as Sir David said, have got to say that they are ill early, as soon as they get symptoms, not after they've had symptoms. So that it's got to be quick in that sense. People have got to be willing to give all their contacts. They've got to be prepared to tell the name of their mates to the authorities, and that's not an easy thing to do. They've got to be prepared to lock down even when they're feeling well, and even when others are going out. Every stage there's leakage. Every stage containing that leakage is absolutely central, and trust is absolutely central. And to have a system where we are giving private data, and we don't know where that data is going to, and we have reason to believe, A, it's being centralized, and B, it might be going to private sector organizations, is going to undermine trust. So it's partly an issue of rights, it's partly an issue of pragmatics. This system, any fittest system, will only work to the extent that people have trust in the way it's being used and the way their information is being used. And without that, it's dead in the water.
Thank you, Professor Riker. Now we're going to go to an anonymous caller, and that's because it's someone who's actually trained as a tracer, and they've asked to stay off camera. So could the contact tracer kindly ask their question to the group?
Hello, hi, yeah, I'm a doctor, and I've been working as a contact tracer. So I was asked to give a little bit about my experience and asked a question. So I feel that our training was very inadequate. We had no session with a human. We only had a Word document with some FAQs to read and some sort of mandatory things on fire safety and such. I also don't believe that there are all the positive cases being uploaded. So I've had over 50 hours of paid time working so far, and I've not phoned a single person. I've only ever seen people come up where it's a glitch because they've already been phoned by multiple people, often having refused to give information or having already given it. There's also lots of other issues, such as no translators being available, so we're unable to speak to anybody who doesn't speak English. So I'm concerned that, the public have given a false sense of security, that we've got a functioning test and trace system from what the government are saying, that we actually don't. And so my question is, what do you think about this? And also, do you think that it's actually possible to have the local GPs and public health teams actually doing the contact tracing, rather than using a centralised national system like the one that is trying to be implemented at the moment?
Well, that's an extraordinary account. I'm looking at the panel to see who'd like to take that question. Perhaps Professor Costello, you look like you're interested.
Oh dear. I mean, what can I say? If people had thought about this back in early February, that we, like other countries, would have wanted to suppress this virus. And we had got everyone together through the NHS, not just through a group at Public Health England, they would be included. And if we had a public health system fit for purpose, unlike the sort of divvied up one that has emerged in this crisis from the reforms of the last few years, then we would have had this up and running by early March. And of course, GPs, we've got the world-class primary care system. The system that's been devised just drives me round the bend, because it's the sort of system that you would, dream up if you had a PPE from Oxford. Sorry, I'm being rude about that. But I mean, it's not fit for purpose. It's not going to work. I'll stop there. I better not say any more.
If we go to Professor Scally and then Professor Pollock, please.
You asked about it. I agree very much with what Anthony said. It shouldn't have been a rushed system. In fact, the whole system should not have ended on the 12th of March. We've wasted 2.5 months, really, and ended up with this huge rush at the end of the day. 2 points. One is, it's not the same across the whole of the UK, of course. Largely, we're talking about the English system, but it is different in Scotland. It's very different in Northern Ireland. Northern Ireland is run by the Health Protection Agency. Scotland, NHS Scotland are providing it. So it's not the same everywhere. The problem in England is just the size of the country and the absence of some of the structures that you would normally look to provide a good service like this to the public in the public sector. There is no longer any regional structures really viable in England, and the local authorities have been diminished in their revenue and in their reach. But nonetheless, it is possible to put that structure together for this purpose. Local authorities, the top tier local authorities, are already doing a huge amount in the context of the coronavirus crisis. And they link very well, because of their housing function, to lots of the support elements that are could be part of an integrated system. The environmental health officers in local authorities, similarly, the public health teams in local authorities now at a local level. But it does need organisation, and it does need a regional control mechanism, because the country's too great for it to be run from Whitehall, and it does need leadership and a good policy in place. And none of those things are in place at the moment. And our report is saying that this is the direction, in our expert view, that we should be going. And we look forward to hearing comments as to how it could best be organised. But organised it must be, and it is not organised at the moment. It is disorganised at the moment.
Thank you, Professor Scally. Professor Pollock, did you want to come in? Yeah.
Just very, very briefly to say I completely agree with Gabriel, but it can be done. It's about political will. And at the moment, the government is squandering hundreds of millions of pounds on contracts which are not even going out properly for tender. And that money could be reinvested locally and regionally, as Gabriel has said. I'll give you one example. The budget for Public Health England for communicable disease control for 1 year is around £89 million. The Randox contract for the testing that went so disastrously wrong, this bit of commercial testing, is over £133 million, and that was for less than a month. So these are the examples. We've got Serco, which may be up to 90 million for contact tracing. If the government had reinvested, which is what it needs to do, in the GP practices, in NHS labs, in public health, and of course, re-putting in the structures that were taken out by the 2012 Act, then we would be able to go forward. And that's what needs to happen.
Thank you, Professor Pollock. We're going to go to Kitty now. Kitty, I know you've been getting in lots of questions. Are there any particular themes or topics that we're seeing come in?
Hi, Zach. Yeah, so we've had hundreds of responses over Twitter, and these speak to kind of three main areas. So the first of these is, as we've sort of discussed, the role of the private sector versus public sector. The second is learning from other countries. And the third is the misuse of people's data during this scheme. So I've got some questions here from Joan Miller, who is from Community Contact Tracers. And she asks, why wait until after the test result comes in to start contact tracing advice and support? Valuable time is lost here. And why stop contact tracing on negative results when the false positive rate is so high and clinical information is available to make a more nuanced decision?
Interesting questions there from Joe. Does anybody want to? Professor Deenan Pillai, do you want to speak?
Hello, thanks for those questions. So with regard to the first question around why are we waiting for a test result, the worry about progressing with isolation, contact tracing and isolation of contacts following just symptoms rather than a positive test result is that we're very likely to overestimate, maybe by 3 or 4 or 5-fold, the number of people who actually have COVID infection. And therefore, the risk of being guided by just symptoms, particularly as the overall instance of disease is coming down, is that there would be far more people contacted and isolated and needing to isolate than would be required, with, of course, the major negative effects that would provide. So I think we feel that testing is needed of symptomatic individuals is needed, and contact tracing needs to be guided by that test. But that brings us on to the second question, which is, I think the term used was false positive. I think the more important one is that's not so much of a problem for these tests, it's a false negative. And in other words, people who have symptoms due to COVID, but in fact test negative, and the reassurance that gives, and therefore the lack of contact tracing and isolation. And I think that is a function of the quality of sample that is taken that feeds into tests. The biggest determinant of a false negative from these specific tests, and they are very specific tests, is that the quality of the sample is not sufficient. And that also plays to our proposal that the large testing centers, particularly the drive-through testing and home self-testing, we know, and there's good data to suggest that the quality of sample taken is suboptimal. These are not easy samples to take, and therefore a local-based testing service linked to, of course, our full integrated tracing and isolation and support system would support, I think, better quality of test results that came back, as well as, of course, the speed with which those test results come back, because, of course, that's wasted time once we've decided we're waiting for a test. Thank you.
Thank you for those answers. Professor Christina Pagel, I think you had a couple of thoughts on this.
Yeah, so just to echo what Deenan said, if you do just start isolating based on symptoms, you risk isolating far too many people. And even if you then went back on a negative test and says you can stop self-isolating, you've still caused potentially some distress as people are worried about what happens and they can't go to work or whatever. But you could potentially take contact at symptom stage and then only contact people once there's a positive test, because you do need to try and get hold of people within 4 days of their contact with a symptomatic person. But I think if you did that, you'd need really strong data governance in place. You'd need to be able to trust that if there was then a negative test, that contact data would be destroyed and not used. But that would be one way of kind of treading a middle ground where you take details, but you don't contact anyone until there's a positive test.
Thank you, Professor Pagel. We can go to another member of the public now. I think we have Saklain Chowdhury. Saklain, are you there?
Hi, my name is Saklain and I'm from London. I'm particularly keen in asking the question in relation to the BAME COVID-19 report. So there seems to be a lack of answers and solutions to the report in terms of keeping BAME frontline key workers safe. The report highlights that BAME key workers are more disproportionately affected by COVID-19, but there are fundamental flaws in offering practical solutions going forward. So I just wanted to ask, what is Independent SAGE doing to ensure that the government provides comprehensive support to BAME workers, especially in those health and social care sectors, but particularly around contact tracing? For test, trace and isolate to be fully effective, we are relying on thousands of people to input their data via an app. So it was related to an earlier question, but when will this app be fully operational, and can SAGE make sure that all the data gathered through the app is kept private and confidential? Someone raised issues about language barriers and trust issues, especially in light of what's going on around the world. There seems to be a lot of trust issues, especially with the BAME community, and there seems to be a lack of clarity in terms of how accessible this system is to members of the BAME community.
Some great questions there, Sakling. I'm looking at the panel to see who would like to take that. Stephen, maybe from a trust point of view in terms of the app, you could talk to that.
Okay. Well, thanks for the question, because I think it raises a really important point, which is that one size doesn't always fit all, and we need to understand how there are different implications of the same measures for different groups in society. Now, somebody earlier asked the question about rushing in this system. Well, at one level, of course, it's quite the opposite. We should have been developing this over the last 4 or 5 months, and it's very late indeed. But at the same time, the way it has been introduced has not done a number of things that I think are critical to have a system that A, is practical, and B, has buy-in from the public. One of the core principles, if you want people to own and take part in a policy, is you involve them in its development, the process so-called of co-creation, so that when you work out the details, you don't just presuppose what the implications will be, you ask the relevant communities. So I think co-creation and bringing in particular groups who might have particular problems with the stages of FITIS, I'm going to stick with that, it is really important. So as you say, the notion of giving information to the state from particular groups, from BAME groups where trust clearly is in crisis, from other groups as well. I mean, one of the non-compliant groups are young men of whatever ethnicity. It's really important to involve them in the process, to talk to them and to understand what can be done. The other element of this, which is absolutely critical, and it was raised earlier, was the issue of support, which we must never forget. The barriers to adherence are very different in different groups, with different family structures, with different constraints. It's going to be very different in certain BAME communities, and will be differentiated between different subgroups of the BAME community. And we need to know what those are, and we need to identify those problems, and we need to put in place tailored forms of support so we can make it practical. I would say we should go beyond just simple support to say that you don't lose out. We're asking people to do something very difficult indeed with isolation. Many of them won't feel ill. They will see everybody else around them going out. We're asking them to make a considerable sacrifice for the sake of their community, and their community in turn should be asking, what can we do to support you and to help you? And what does that mean in different ways for different communities? So taking into account the BAME issue, and more broadly taking into account the different needs of different communities, involving them in the process and tailoring forms of support is critical to the success of this process.
Thank you, Stephen. Professor Scally, you've got your hand in the air there.
Yes, I just want to say two things. Firstly, that we, of course, saw the report that has been issued by Public Health England about BME and the terrible toll that BME communities are facing with coronavirus. And we shared the widespread disappointment, both in the content of the report that was published and also disappointment in what appeared to be some censorship or alteration of some of the inputs into that report. And I can tell you that we're thinking hard about our work program for the next period of time, and we are considering whether it would be valuable for Independent Sage to look at these issues and provide some advice that would be authoritative and hopefully shift the debate on, because action is needed and we can't wait forever for something to happen, and there is no sign of anything happening. So I think it may fall to us to grasp this nettle and come up with recommendations in respect of these extraordinarily important issues. And thank you for the question.
Thank you for that, Professor Scally. Sakhalin, did that answer your question?
Yeah, no, there's some great responses, but one thing I just wanted to highlight is clearly over the last few days, few weeks, the level of trust or trust issues has gone down, and there are real concerns regarding the government's response to the crisis in terms of from a BAME point of view. And from the beginning, it seems to be that the approach has been, there hasn't been enough of a stakeholder point of view where they've involved different stakeholders from the BAME community, and the government have been really lacking in involving different members of the BAME community. So it seems to be that the contact tracing app going forward, there's not enough of a system in place that involves different members or a wider scope of the BAME community.
Thanks, Sakhalin. Professor Pielank, do you want to come in?
Just to add to the others and to thank Sakhalin for your comment. I mean, we're at a time when these two crises that are within us, both the COVID-19 pandemic and then the violence in the US that's raised again the inequality in society, and the importance to restate that Black Lives Matter, is these two issues are coming together actually within our response to the pandemic. And I would just agree with the others. It is an opportune time to really make the case that Black Lives Matter in the context of our response to the pandemic. So I'd support your thoughts, Sakhalin.
Thank you. So now we're going to move on to Alex Crozier. Alex, are you there?
Hi, yeah. Yes, my name's Alex Crozier. I'm from Newcastle and I'm a PhD candidate who is involved in science communication. Just before my question, I'd just like to thank everyone on Independent Sage for all of their hard and really quite amazing work and for really flying the flag for transparency in science. So my question is, unlike in some countries who have successful contact tracing strategies, the UK is only tracing the primary contacts of a patient. I understand there is evidence from the BBC pandemic study that tracing secondary contacts results in a lot of people quarantined in a similar way to general social distancing, but that model was actually a mitigation, not a suppression scenario. Given there are already concerns about poor public compliance to test, trace, isolate, and also importantly about the time pressures at every level of the system, such as the previously mentioned delay of about 2 hours of symptoms before ringing for a test, and having to wait for a test result to come back before tracing begins, therefore allowing 72 hours potentially of transmission or another viral cycle. Would it not be advisable to also trace secondary contacts to really drive R and the total number of infections down to enable us to properly reopen society? And also just quickly, on the topic of learning contact tracing strategies from other countries, should we also be considering doing cluster busting or retrospective tracing, which is tracing backwards with the aim of finding the common source of infection to identify all transmission chains? And this seems to be quite a successful strategy in Japan at the moment, especially against super spreading events.
Thank you for those questions, Alex. I'm going to throw to the panel. I'm conscious of time and we've got a few more questions. So if we could keep an answer fairly brief. Professor Christina Pagel, would you like to jump in?
Yeah, just to say that the current assumption is that for each person who is an index case, there'll be maybe 10 close contacts that you might want to isolate. And if you then add to that their secondary contacts, and that's 10 each, then that's going from 10 to 100 people for each index case. And I really think that is a lot of capacity. And as far as I know, there aren't any other countries that are doing secondary contact tracing that are successfully managing the pandemic.
Professor Alison Pollock?
Yeah, just to add to that, Germany reinvested in its contact tracing system really successfully. And it didn't do any secondary contacts at all that I know of, and it restricted testing only to suspected cases. But it was very fast on the uptake, and it put in the financial package that was necessary. And it did do, you're absolutely right, it's really important to go back in time retrospectively, as you say, the cluster busting, and identify clusters of cases and work that out as well. And that's really part of the basic role of public health. That's what public health has been doing as part of contact tracing forever. But of course, we've missed out on all those opportunities, because the really key thing is that suspected cases, patients with symptoms, are not being notified because they were told to stay at home and not go to their GPs. And NHS 111 was not set up to notify suspected cases, which is why the system is broken and why we don't have community prevalence data and why we haven't been able to get contact tracing off the ground. So it starts with the symptomatic patient reporting to the GP, who then notifies us and orders the test.
Thank you, Professor Pollock. I'm going to move us on now. We've got a question from Dr. David Trisker, a GP in Wales. Dr. Trisker, would you like to ask the panel a question?
Hi, thanks so much. My question was really about the role of general practice. I know this has been somewhat covered, but it feels like we've been neglected throughout this pandemic, and we've been chomping at the bit to try and get hold of testing and tracing, and we've always been on the back foot, having things centrally dictated to us. Does the panel feel that primary care going forward should have an integral role in the control of the spread of this virus?
Absolutely.
Professor Scally, would you like to kick us off on this one?
Yes, absolutely crucial, David, for general practice to be involved. The facilities and the staff and all that effort locally, the clinical commissioning groups and the other primary care organisations are there, working with local authorities, which I know primary care does a lot in its organisation. And it is amazing that we have all of this NHS resource and capacity, and we're not taking advantage of it. And I hope you'll contribute to this consultation and make the point about the extremely great importance of primary care, and not just GPs, but all the other members of primary care teams. Thanks for the question.
Professor Costello, would you like to come in on this one?
Yeah, just to add that, I mean, look, GPs are the absolute backbone of our NHS. That, you know, if you feel sick, if I develop symptoms tomorrow, I'd email my GP, and, you know, your GP, she will, you know, reassure you, because if you get a positive test, a lot of people will be really worried. You know, they'll think they could be in hospital in a week's time, or even dead. You know, you need that reassurance. You need somebody to monitor you. You need somebody to refer you. You need somebody who knows your close contacts already, because GPs are often looking after your close contacts as well. And just to monitor the whole progress of it, and the longer term sequelae, if there are, because a lot of people who have moderate COVID are ending up with, you know, a lot of long-lasting symptoms. So the idea that you exclude GPs from this, to me, is absurd. It doesn't mean that every GP has to be involved in helping the system develop, but we have to have that as the framework, in my view. And thank you for your, because every GP I've spoken to has said this, but I've spoken to some senior people, say no more, who in public health, who say, oh, no, GPs aren't interested, which to me is absurd.
Thank you so much for that question. It's clearly a key topic going forward. I'd like to go to our last member of the public, if I can, which is Saba Mann. Saba, are you there? Maybe not. So Kitty, I think that you might have a couple more responses from contact tracers. Is that right?
Yes, yeah, we got quite a few of those. They've all asked to remain anonymous, but I can read you a couple of accounts. So the first one is, I'm working as a contact tracer. I can say I have received 4 weeks pay now, but haven't been given a single contact to call. out of 200 tracers at my agency, we have only had 4 contacts to call between us in 4 weeks. There is no data. For whatever reason, test results are not being passed in time to tracers. It's an absolute scandal. And I've got another one. She says, I was offered a role 3 weeks ago and I'm still waiting for a training date to be confirmed. I spent approximately £500 on the equipment required, including a laptop and telephone headset. I spoke with the recruitment agency today and they're unsure if the role will now be going ahead due to low volumes. And then finally, we just got a question about test, trace, isolate. And this is, how flexible can and should the TTI system be?
I'm looking for hands. Professor Pillai, would you like to start us off?
Well, just further incredulity at what's happened, and to place that that comment and contribution from your anonymous, our anonymous caller, into context. We estimate that there are 5,000 infections per day at the moment in the UK, across the UK. And on the basis of 10 contacts per person, that would be 50,000 contacts. Now, we appreciate that not all those 5,000 estimated infections are symptomatic, and therefore not all of them would precipitate a test. But even if we cut that by half, we're talking about, we should be dealing with at least 25,000 contacts per day at the moment. And we're hearing from tracers who are just sitting, twiddling their thumbs. It's abysmal.
Anybody else like to come in on that? Or let's move on. I think Sabah Shortcut. Sabah, I think I got your name wrong, so apologies for that. Are you still there? Maybe not. Okay. Professor Pollock, did you want to come in? I saw your hand on the last question, or shall we move on? Professor Pollock?
Just very quickly, to say we've got on the basis of 5,000 cases a day. You were talking roughly about 5 cases in each local authority per day, and so this is not a huge number, and it would be really manageable if it was being done locally in each system. So you'd have about 50 contacts. And think about it, Germany has capacity at the moment for 50 cases per week in each of its local authorities, which is actually smaller than what the UK has. So, and then they have a call down capacity. So this is quite shocking, as Dinan says, that we're getting so many accounts, very powerful accounts, of the money that's being squandered and the opportunity that is being lost. Thank you.
Professor Pagel, I think you also wanted to just say something on this.
Yeah, so what really worries me about the anonymous caller thing saying they don't have any contacts to trace is that, as Dinan said, even if you just think about symptomatic people, there should be about 3,000 a day. And what worries me is that people don't know that if they get symptoms now, they should ask for a test as soon as they can. I mean, that is government policy, but there hasn't been a big campaign around it. And so if people don't know, you're missing the very first bit of test, trace and isolate, which is find cases. So, I mean, unless you have that, you can't do contact tracing. So I think that is just a really big issue for me. Like, why do people not know? What can the government do to help people understand that they should be getting tested and help them work out how they can get tested?
Thank you, Professor Pagel. We're going to have one more member of the public before we throw over to our media, who we've got some of here. The final member of the public is Rachel Wyatt. Rachel, are you there? I can see her name. Let's give her an opportunity to unmute. No, we'll move on. We'll move on to the...
Can you hear me?
There we go.
Yeah, apparently you've turned off my video.
That seems cruel. Try that.
Okay.
If not, there we go.
Hello. Hi, good afternoon. I'm Rachel. I'm from the New Forest in Hampshire. I have a couple of questions on special needs children. A lot of the discussion has surrounded mainstream children, but the vast majority of special needs children travel to and from school using taxis or school minibuses, perhaps. with the imminent return of year 10 and 12, I'm wondering if there's any consideration of the risks to the pupils and drivers and support staff accompanying the children.
I'm looking for a hand. Who would like to Professor Costello, maybe you could come in on that.
Yeah, that's, I mean, obviously, it's interesting that you raise the issue of the drivers and the support staff, because you're absolutely right that they are the most vulnerable in this setting, because most children with special needs, and all children, in fact, generally either get a virtually asymptomatic infection or very little in the way of symptoms. But you're absolutely right. I mean, if you look in London, I can't remember the exact death toll of bus drivers and taxis drivers, but I know it was very high. And so really, they should now be protected in exactly the same way with masks, and ideal with a perspex separation, which is what a lot of taxi drivers and buses have introduced. So I agree with you, and I thank you for your question.
Anybody else would like to come in on that? No, I think we'll. Oh, Professor Alison Pollock would like to come in.
Rachel, you might like to look at our schools report that we put out last week, where we were really thinking about the needs of children and vulnerable children. You're really right to highlight those needs and the fact that the government has not been proactive enough in meeting those needs. So if you need any help finding that, we can give you help finding the schools report, and we'd be very happy to take more questions from you later.
Absolutely.
Thank you very much.
Brilliant. So that concludes the questions from the public. We now have some media in here, I hope. We are going to go to Fred from ITV. Fred, are you there?
I'm hoping so, but I'm afraid my video is not working.
Not to worry, we can hear you.
Great. Just wanted to ask, so speakers criticised the current system, but what would you do immediately as kind of a first step to change it?
A first step. Would anybody like to tackle that? I will go to Professor Scally.
Yeah, well, I think the first step is to put a strategy in place, write a strategy. It doesn't have to be enormously long at this, if you're looking for an absolute first step, and just produce a commitment to put a fully fledged system in England in place, and that it will be based locally. I think there are about between 5 and 10 crucial points that will make for a successful system, and they are largely absent from what's in place at the moment. So I don't think it has to be just one thing. It has to be a group of strategic approaches agreed and then implemented quickly. One of the first things I would do, I would talk to NHS England. The NHS has, and we've heard from GPs, for example, about the role that they would like to play and wish they were playing. And we should be talking to NHS England about how we can put a structure in place to support what's going on at local level, and talking to the LGA about top tier local authorities and their fantastic contribution that they could make, and get their agreement and their involvement in developing a working strategy, which would only take a few days to put the bones of that together.
Thank you, Professor Scally. Professor Costello, I think you'd like
to... One thing that you could do immediately is to rename this program, as we have, FTTIS, Find, Test, Trace, Isolate and Support. Because as Christina Pargle has just said, you've got to find cases and they've got to know exactly what to do at speed. A good bit of news that's just come out from WHO is that we know that about 40% of people are probably asymptomatic, but they think that asymptomatics don't, by and large, pass on this infection. They think that's quite rare. And they've got some data that hasn't been published yet, but they've been looking at this in great detail. So that heightens the need to have a really good system that finds people. But ultimately, the government have been focusing all the time on this test and trace, as though that's all you need to do. And the more tests you have, the better it is. The key thing is to isolate. That's what you're trying to do, is to isolate people who've got infections quickly to stop them spreading, and their contacts that may be doing that. And if you're going to isolate, that requires support, which is the financial incentives and the facilities that you need to support people. And without that whole integrated system, just focusing on test and trace is kind of doomed to fail. So having a name that represents the system as a whole is very important.
Thanks, Professor Costelli. Professor Riker, do you want to dip in on this before we move on?
If I could. I just wanted to pick up on the point about strategy. I mean, if you look historically at adherence to preventive measures in previous pandemics like H1N1, the critical point is whether people realize there's still a problem and whether they feel it's important to comply. And I think one of the greatest problems at the moment is there is no overall clarity of messaging. There's a rather vague sense that things are getting better and we can relax. We can have happy Mondays and we can go out more and we can go shopping. I think it's absolutely central that people understand that the infection hasn't gone away. It's still out there. It's out there in lower numbers, but what that allows us to do is, instead of having the blunt instrument of lockdown, we now have a targeted strategy. And that targeted strategy is FITIS. Now, the reason why that's so important is, again, to say to people, it's not that you can just relax. It's that we can open up in some ways, but it is contingent on being more vigilant in other ways, in terms of social distancing, in terms of hygiene, and in particular, in terms of this system working. People have got to realize that without that, if you just take away the blunt instrument of lockdown without a targeted strategy, we'll have a second wave. And that going along with this system is absolutely central to our safety. So I think the overall message, the overall framework, the overall understanding that, it's a bit as if, there was a venomous snake, a dangerous snake that was thrashing around and biting people and killing people. We've got our foot on the neck of that snake. But if we now take that foot off, it will bite back and there will be more deaths. And that understanding of seriousness, I think, is absolutely critical, and I think just simply isn't there in the desperate desire to give people good news and not be clear about the reality of the situation.
Thank you, Professor Riker. So, David, do you mind if I move on to the next question? We have a lot to cover. I'm going to move on to Andrew Woodcock from The Independent, if that's okay. Andrew, I saw you there a moment ago.
Hello, yes. I was interested in the testimony which you just read out before at the end of the public session from people who are actually taking part in the contact tracing system, who appear not to be being given cases to contact. They're not being given work to do. What do you think is the reason for that? Why would it be that they've got these 25,000 people and they're not finding adequate work for them to do? Because surely there are people to be traced.
Just one bit of data. We saw the data that Jeremy Hunt in the Select Committee tried to get the data out of Baroness Dido Harding, and she didn't release it, but I believe she's been asked to release it later this week. But the data after 6 days of running the programme was, I think, that there had only been 1,500 or so contacts actually traced. So, I mean, it's a very low number, and that's why of the 25, that was over 4 days, I think. So 1,500 over 4 days, that's why so many of them are sitting twiddling their thumbs. I mean, one would have expected it to have gone up by now, but the other thing they found was that only 2.5 contacts per case were reported. So there is a problem there, and it'll be very interesting to see later this week what data she actually releases, because there are some very good indicators of performance that the Select Committee have asked for.
Professor Scally, did you want to come in as well? Or no? Okay. Let's move on. Do we have Caitlin Doherty from the PA there?
Hi. Is that connected? Sorry, I've been having some connection issues.
No problem.
Yeah. So my question is probably quite closely related to the first one. In your report this morning, you said that people, 80% of contacts need to isolate for 14 days if this is going to be controlled, but that currently isn't happening. do you think that with how attitudes to lockdown have changed and maybe become more lax in the last couple of weeks, do you think there is a possibility of that ever happening?
Sir David, would you like to come in on that? You're on mute.
Let me say very quickly, I think what has happened is a loss of moral authority. And so what is really needed now is to renew the system. And this means admitting that this system is not functioning. Every single day that passes with a dysfunctional system means longer before we recover from this pandemic and get back to economic stability. So I think we actually need the leaders in the country to regain moral authority by saying, yes, we agree this is not functioning, and we need to go back and use the local systems that we've been talking about.
Thank you, Sir David. Professor Pillai, do you want to come in on this one?
Yeah, briefly, just to add to that, is one of the recommendations we highlight in our report for consultation today with yourselves and previously is to have some key performance indicators of this system. And that's one of the problems. And you identify, you're asking a specific question about the number of contacts traced. But that only has meaning in the context of how many people have been found, how many people tested. And this is a pathway, an integrated system. So again, I just want to emphasize that the quality of the data, even if the data were released, the quality of the data so far is inadequate to be able to say anything about how the system is performing in order to prevent new infections.
Thank you. I'd like to move on to a question from Alexandra Thompson from Yahoo. Alexandra, are you there?
Oh, yes. Hello. I'll get my video up. Maybe. Hi, everybody. So you're clearly keen to have GPs and primary care physicians more involved. So just so I'm clear, do you think they could handle it by themselves, or do we need them in conjunction with these trained tracers, because they're twiddling their thumbs at the moment? So how big a staff do we need? Can GPs do it alone?
Professor Alison Pollock, you'd like to come in?
Yes, I think the important, I don't know whether you can hear me, the important thing is that the reason why the GPs are so important is because where most patients go to report their symptoms. And the whole contact tracing begins with the patient reporting symptoms to the GP, and then the GP notifying the local public health department of a suspected case. And that's when the public health department will activate contact tracers. At the same time, the GP will then order a test from the local laboratory, and that test is what comes back to tell the patient and the GP whether the case is an actual case or still or a suspected case because it's a negative test. So the GP is really pivotal, and that is the basis of our legal notification system, which is what the government is not following. If it had followed that, we would have had a much better sense of the patients out there, the numbers of suspected cases, the numbers of confirmed cases, which we don't know at the moment. And then we would be able to reactivate contact tracing. But everything starts with the symptomatic patient who then reports to their GP or NHS 111 just now. And that's another recommendation, is that NHS 111 would need to be integrated back into primary care for the COVID.
Thank you, Professor Pollock. If no one else wants to come in on that one, let's go to Fiona Godley from the BMJ, please.
Thanks very much, Zach, and thanks to Independent Sage for this very good, hard-hitting report. I've got a couple of questions. First is, Nature article published today shows that lockdown has had a dramatic effect and saved millions of lives globally. Would lives have been saved if a proper track, trace and isolate system had been in place in the UK since mid-March? And if so, how many, hard to say perhaps. And then I just wanted to ask, how easy will it, in your opinion, be for this government to pivot from its current approach to the one that you're proposing?
Professor Christina Pagel, maybe you can come in first here.
I mean, I think lives would definitely be saved if there was a proper test, trace and isolate program earlier than mid-March. In a sense, once you have lockdown is isolating everybody. So you've kind of done the massive intervention. What test, trace and isolate should do is help you prevent lockdown to begin with. So you need to do it as early as possible. Once you're in mid-March and we were having, tens of thousands of cases a day, then it becomes almost impossible.
Just Fiona, just to remind you of what happened in China, for example, in Wuhan, 11 million, they brought in 9,000 people to go round and help with a partial lockdown and the find, test, trace stuff. We had 210 people in February working on this, and we only traced 3,000 contacts. So we didn't do it. And in Korea, they set off with theirs when they'd had 3 deaths, and they did a partial lockdown in the provinces that were affected, and then they did this intensive find, test, trace, and they suppressed the whole thing in 3 weeks, and they ended up with about 250 deaths. Greece locked down before they had any deaths. As soon as they picked up some cases, they said, we're not going to be able to do the find, test, trace. They locked down. They've ended up with 150 deaths. We could have locked down March the 3rd when we had the same number of deaths as Korea, or even earlier if we wanted to, or we could have set up a find, test, trace, isolate system if we had immediately, early on in February, not ignored, done it all through Public Health England that clearly didn't have capacity, but mobilized our primary care and district authorities. And I think we could have done the same. So could we have saved thousands and thousands of lives? Yes. Brutally, yes.
Professor Pillai, maybe for a final word on this one, or I think everyone has things to add here, but if we could.
Well, thanks, Fiona. I just wanted to raise your second point: is it possible for government to pivot? And we're here. We're not an oppositional group here. Independent Sage is all about being constructive and coming up with proposals that are deliverable. And I don't think. I think it's perfectly feasible for a pivot to occur, and it's important because, of course. This whole process of find, test, trace, isolate, and support is going to be more and more important as we go through further waves, locality-based waves, and so forth. So now is the time to actually start to decentralize what has initiated a centralized system. Let's say, for instance, the Lighthouse Labs are staffed by volunteers. That's not sustainable. There needs to be a migration back of testing back to NHS labs. There needs to be public health directors involved, as in fact some of the government ministers are now starting to say. So I think we want to just encourage the speed at which that pivot goes back, and we identify in our listener consultation report, which will be more detailed later on this week, around some of the mechanics of how best that can be done.
Professor Scally?
Fiona, just one point, and that is, it's not a question of pivoting to FTTIS alone. And one of the major problems, I think, has been seeking the silver bullet at any point in time and neglecting the wide range of public health measures that are necessary. They should all be on the table, they should all be in play, and they should all be used to their most effective extent at the time. Instead of this picking and choosing things and abandoning tracing on the 12th of March and then antibody testing and then abandoning that as the silver bullet. It's all of the things all of the time, and they should all have been in play right at the very beginning.
Thank you. I'm conscious we are running rapidly out of time. Do we have Colin Fernandez from the Daily Mail here? No. Isabel Shaw from The Pharmacist?
Yeah, I'm here.
Ah.
Hi. A few questions. So pharmacists and pharmacy bodies are concerned that the new test, track and trace programme will result in lots of pharmacy closures. Many pharmacy contractors say they will not be able to recover from a temporary closure financially after years of underfunding. Should pharmacy teams and healthcare professionals be exempt from the programme in certain circumstances? And also, should pharmacies that do have to temporarily close be financially supported? And also, what do you think the effect will be on a local level if many pharmacies in one area are forced to close?
Professor Pollock, would you like to come in first?
This is a really important question because access to pharmacists and pharmacies is really vital. And what we're seeing is a decrease in areas of high deprivation. There have been some studies showing that. So, of course, it would make absolute sense that pharmacies are supported to deliver and helped if they're under pressure and if the whole team has to go into isolation or quarantine. So it's like all the other essential services, they need to be supported by the government if there's an outbreak in among staff in the pharmacy. I think that's answered your question, has it?
Yeah, that has. Thank you.
Thank you. I'm going to throw to Mimi Lorna from Nursing in Practice. Just before I do, can I ask any journalists who still would like to ask a question? Can you raise an electronic hand? Otherwise, we'll end it here. So, Mimi Lorna, can I pass to you?
Sure. Hi. You mentioned that community nurses should have a bigger role to play on a local level. First, could you share some specifics on what that might involve? And second, should the school nurses and other public health nurses who have been redeployed in very large numbers in some regions be called back for that to happen?
Who would like to tackle this one? Professor Scally.
Well, I think community nurses are absolutely vital, from practice nurses, school nurses, health visitors, that entire workforce. You've got, although we do have to remember that their numbers are much diminished. There are only 2,000 school nurses, for example, in England now. 10 years ago, there were 3,000. And the school nurses, I'm sure, are fully engaged at the moment in trying to cover the schools and make sure the schools that are open, at least partially, are helping their pupils to the maximum extent. But I'm absolutely clear that the nurses and the infection control nurses as well, that are part of local public health teams, have a fantastic job to undertake. And I think that's part of an early discussion, a part of the pivoting. If we go to this FTTIS system, that the discussion with the LGA, with the local authorities, with the NHS, and all of the components of the NHS, that's what will be being discussed. How to bring that very skilled, very experienced workforce together at a local level. Thanks.
Thank you, Professor Scally. Professor Costello?
Just to add, it's not just about community health workers and primary care, it's also about the community generally. If you look through this epidemic, there's thousands and thousands of mutual aid groups have sprung up, WhatsApp groups, Zoom groups, to provide support. And many people have felt very strengthened by all of that. And it is going to be very important. I mean, I read a disturbing report yesterday of a number of old people being found dead at home, days or even weeks after the death had occurred. And this was because they were isolated and nobody knew they were sick, and they obviously died from COVID. And I don't know how many cases there were, but this is clearly an issue. And so mobilizing communities is fundamental for the support component. And people can add a huge amount to that, helping with getting supplies in, offering support, and keeping an eye on people, particularly those who are vulnerable.
Professor Pollock, I think you wanted to also come in here.
Yeah, I just wanted to say that we are not drawing enough on the community in many ways. There have been extraordinary examples of volunteers setting up contact tracing initiatives in Sheffield and now in Upper Calder, and working closely with the directors of public health and GPs, also in inner city London. And I think this is an extraordinary testimony to the goodwill of people and how much they want things to work. We've also got the 750,000 volunteers who volunteered for the NHS. So there's no lack of willingness. And this is where the local contact tracing is so important, because local authorities and local health bodies understand and know their populations and can draw down on those skills much better than Serco, who's doing the big call centres at the moment.
Professor Ryker, do you want to say some words?
I mean, I think this takes us back to the core issue of trust. And in terms of pivoting, I mean, as has been said, we're not a political group, but I think we can say something from behavioural science as to what needs to be done to rebuild trust. I think the first thing that needs to be done is to be open and a little bit more humble. Every time I hear a promise that we're going to have a world-beating system or world-leading system, it feels to me a little bit like chalk dragging on a blackboard. Because people talk about parenting, they talk about good enough parenting, and I think we should aim at a good enough system that's actually up and working. And I think people would trust it much more if there was an acknowledgement of the failures, an openness about the limitations, and a little bit more realism about the targets. It's a key system, and the key thing is to have it functional. The second thing that I think is absolutely critical in this is to draw on the population, as we said. That I think the headline of this entire pandemic is just how well the public have behaved through a lockdown and beyond. I mean, nearly 90% people complying, despite the fact that 44% of them were suffering. And as was just pointed out, we've had 4,100 mutual aid groups involving more than 3 million people. They're a critical resource to be used. And the third thing, rather than going for very glossy technologies or to go for very bombastic national systems, draw on local trusted systems. People will be much more willing to give their information to a community nurse than to an app or to some sort of impersonal system. That we need to, in a sense, it's the old slogan, right? Let's act locally, then we'll build something global that will actually have an effect. So, as I say, a little bit more realism, a little bit more humble, a little bit less bombast, and draw on the community, and you're going to have a powerful system that actually works.
Thank you, Professor Ryker. I think there's some very good words to wrap this up with. I'm just going to pass it to Sir David to perhaps say some very final words as we bring this to a close.
All I want to say is that we greatly value the public feedback that we get from these exercises. It's a critical part of what we're doing. We want to demonstrate transparency, we want to demonstrate openness and honesty, and how this plays back in terms of what Professor Ryker was just saying, to gain trust. And really, that is, today, again, has been a wonderful demonstration of just that.
Thank you.